Good afternoon or good morning, everyone, depending upon what time zone you are in. I hope it is a nice day wherever you are. Today's webinar is brought to you by the TA Network, whose logo you see in the upper right-hand corner of this slide. The TA Network is the Technical Assistance Network for Children's Behavioral Health. It's housed at the University of Maryland School of Social Work, but the network consists of many partners whose logo you see on this slide. My name is Jane Walker, and I am the Executive Director of the Family-Run Executive Director Leadership Association, or FREDLA. We are a new organization developed by a group of 16 executive directors of local and state family-run organizations, and we're dedicated to building leadership and organizational capacity of family-run organizations. FREDLA is one of the partners in the TA network, and we are pleased to be presenting this webinar to you today on this very timely topic for family-run organizations as well as state Medicaid and mental health agencies. But we are not doing it alone. We want to acknowledge the Substance Abuse and Mental Health Services Administration, Center for Medicare and Medicaid, the National Technical Assistance Network for Children's Mental Health, the Center for Healthcare Strategies, and note that this webinar is based on a recent publication put out by the Center for Healthcare Strategies entitled Becoming a Medicaid Provider of Family and Youth Peer Support, Considerations for Family-Run Organizations. On our panel today, we have the primary author of the publication, Diana Simons from the Center for Healthcare Strategies, along with two other co-authors of the publication, and later on we're going to tell you how to get it. But right now, I'm going to turn it over to Diana. Oh, excuse me, no. I'm going to introduce our presenters. We're very honored to have John O'Brien from the Center for Medicare and Medicaid Services. I mentioned earlier Diana Simons from the Center for Healthcare Strategies, Jane Kalal, the Family Involvement Center in Arizona, Lisa Conlon from the Rhode Island Parent Support Network, and again, myself, Jane Walker. Now I'm going to turn it over to Diana.
Thanks, Jane. I have the great pleasure of introducing you to John O'Brien. I met John several years ago when I worked at the Office of Medicaid in Massachusetts, and he was at the Technical Assistance Collaborative. We were implementing the court-ordered remedy in response to a landmark federal EPSDT lawsuit in the state, and John was the court monitor's lead consultant. He helped us in crafting state plan amendments for several new home and community-based services, including intensive care coordination and family support and training, and in navigating the redesign of our children's behavioral health delivery system. John is currently the Senior Policy Advisor for the Disabled and Elderly Health Programs Group at the Centers for Medicare and Medicaid Services. Before joining CMS, he was a Senior Advisor to the Administrator on Healthcare Reform at the Substance Abuse and Mental Health Services Administration. He was director of several national projects funded by the Robert Wood Johnson Foundation to develop strategies for coordinating federal, state, and local dollars and funding for human services. Prior to his work at SAMHSA, John worked as a senior consultant with TAC, the Technical Assistance Collaborative, for 15 years. He's provided consultation to over 30 states and local human service authorities, and has also worked with Medicaid and mental health and substance abuse authorities at the state level. His state work has included the development of federal Medicaid waivers and Medicaid state plan amendments and federal grant applications such as the Children's System of Care. John has been a manager at KPMG Harwick, worked for the Eunice Kennedy Shriver Center, the Massachusetts Developmental Disability Council, the Illinois Governor's Office, and the Illinois Legislative Commission on Mental Health, Mental Retardation, and Substance Abuse. And early in his career, he was a program staff at Thresholds, Inc. in Chicago, which is the oldest and largest provider of recovery services for individuals with mental illnesses in Illinois. We're really happy to have John with us this afternoon, and unfortunately, due to other commitments, he's going to need to drop off right after his presentation. So without further delay, please welcome John O'Brien.
Thanks, Diana, and thank you, Jane, for inviting me this afternoon. Good afternoon, everyone. I am John O'Brien. I'm with the Centers for Medicaid and CHIP Services. I wanted to talk a little bit about our involvement, specifically as it relates to services for individuals with mental health and substance use conditions. You may have noticed, or maybe not, over the last 4 years that the Centers for Medicaid and Medicare and Medicaid Services have made mental health and substance use services for individuals, including children, youth, and families, a priority. Over the last several years, we have identified 5 goals that we want to implement over the next several years as it relates to mental health and substance use services. I want to talk a little bit about those goals before I talk a little bit about the bulletin that we put out last year. I think that might help understand the bigger picture of what we're trying to accomplish in this space. And they're fairly simple and straightforward, but I can tell you that they are challenging to implement, and challenging in a good way to implement because there's many moving parts. Our first goal, and one that we're very committed to, is the effective use of screening of mental health and substance use disorders, and specifically not only just good screening, but good strategies to refer and effectively treat individuals when those conditions are identified. Second, increased access to behavioral health services for persons with serious mental health conditions or a combination of serious mental health conditions and chronic disorders. We know that many individuals, including some children and youth, do have a combined mental health and substance use disorder, or combined mental health and primary care disorder, and we feel like integration of care is critical. Our third is similar, or not too far off from our second, but we thought we needed to really say it out loud, which is improved integration of primary care and behavioral health, and for adults and sometimes children, long-term services and supports so that we get better health outcomes for individuals with mental health and substance use disorders. We really believe that there isn't a reason why we should expect less in terms of the various both mental health and physical health outcomes for the general population as we do for individuals that might have a mental health condition or a substance use condition. Fourth, and this is, I think, tied to our discussion this afternoon, which is better availability of evidence-based practices to enhance recovery and resiliency and reduce barriers to social inclusion. And then last but not least, strategic development, implementation, and testing of new benefit designs and service delivery models. And once we test those, bring those to scale. And while that has been typically the purview of our sister agency or sister entity in the agency of our Centers for Innovation Center in the Medicaid and Medicare space, we like to think that we have some room here within the Disabled and Health Program Group, since we have so many opportunities in a variety of authorities. So what have we done to implement those goals? And we've done a number of strategies to implement those goals. Most states, when they look or seek to add coverage, and the good news is that some states are actually adding coverage, they have to submit an amendment to their state plan amendment or their state plan, and when reviewing the state plan amendment, we use the various both the goals and some of the documents that we've put out over the last several years in our review of those state plan amendments, encouraging states to be able to really think more broadly and futuristically about some of the benefits that can be reached through the typical state plan. We also have demonstrations. We have both legislative, congressional demonstrations, the most recent one being the Psychiatric Residential Treatment Facility demonstration that just ended about a year ago, that, again, generated some terrific information and terrific outcomes that we were able to use to be able to support the case for parent and youth peer support services. We also have the Balancing Incentive Program, which is a time-limited program. We're into about our third year, that enhances funds to states who are thinking about better integration, better balancing between long-term care, which can include on the kids' side long-term residential care and community care. Certainly our Health Homes Initiative is an important, while not technically a demonstration, it is a demonstration because we are allowing states to be organic in the way that they approach primary care and behavioral health integration. And then, of course, our various 1115 programs, which by their nature are research and demonstration. We also have some future budget initiatives. I don't know if you had the opportunity to see that there is a budget initiative in the President's 2015 budget that focuses on children in children and youth in the foster care system that utilize psychotropic medication, and specifically that initiative is not just about how to address the use of psychotropic medication, but also how to address the evidence-based practices that those youth are going to need or could benefit from in order to be able to reduce their experience with trauma. And last but not least, we have informational bulletins and we have state Medicaid directors' letters. And I think that's really the genesis of what you may have seen as it relates to our information in this area around parent and youth support services. We have done a number of informational bulletins and state Medicaid director bulletins for children and youth. One of them, again, focusing on youth in foster care, doing that collaboratively with our partners at the federal level, ACF and SAMHSA. We did one on screening of mental health and substance use disorders among children and youth, and that really, again, did focus on the need for our state Medicaid directors to pay more attention to screening for mental health and substance use condition among children and youth as part of what's required under the early and periodic screening, diagnosis, and treatment program. We released State Medicaid Director a little over a year ago around the Mental Health Parity and Addiction Equity Act, again clarifying that for kids that were participating in the CHIP program that MAPIA does apply and how MAPIA does apply. And then last but not least, we did a bulletin in May that was, again, joint with SAMHSA around the coverage of behavioral health services for children, youth, and young adults with significant mental health conditions. And in that bulletin, we identified several services that we believe were effective with these populations. Again, some of this really coming from our experience with the PRTF program. And those were care coordination, intensive in-home services, mobile crisis, and last but certainly not least, parent and youth services. So that if you look at the slide that's up there now, this was our language that we used to be able to message clearly, certainly to our state Medicaid partners, but also to others, that is part of our ongoing efforts to support peer support services, that this was not just about an adult service, that this was a kid service as well and a parent service. As Diane had said, we had actually had some good experience in Massachusetts and some other places in terms of getting CMS's approval around this particular service, and so we felt like we needed to say it a little bit more formally and a little bit more out loud for people to understand that we were serious about this particular service. So if you want more information, I encourage you certainly to call anyone on that's leading this webinar, but there's also some information that you can get from the CMS website if you follow that link that's on this page. And of course, if you have any questions, certainly feel free to call us here at CMS or even call your state Medicaid director who may be helpful in being able to answer some of your questions. So thank you for allowing me to participate. I've probably gone over too much, but I will turn it back to either Diana or Jane.
Thank you, John.
Thank you, John. Thanks, John. So I appreciate Jane's earlier introduction, and we won't bore you with another one. I just want to say I'm a senior program officer at the Center for Healthcare Strategies, and in addition to being the lead at CHCS for the Technical Assistance Network, I'm also the project coordinator for a 5-year multi-state learning collaborative funded by CMS to improve the quality and cost of care for children with severe emotional disturbances who are insured by Medicaid and CHIP and their families. It's through that grant and the collaborative process shared between the lead grantee, Maryland, and partner states, Georgia and Wyoming, that the Center for Healthcare Strategies developed first the scan of states that are using Medicaid to fund family and youth peer support. That was back in 2012, and subsequently the how-to guide that we're referencing today. So without that collaborative and without Jane Walker actually at one of our collaborative meetings saying, hey, it would be great to know in which state Medicaid is paying for family peer support, we would not be talking with you today. So I had to put that plug in for Jane's question originally. So next slide, please. Medicaid financing for family and youth peer support varies from state to state. Some use state Medicaid plans and waivers as funding. So sorry, I had reversed my slides and I reversed my speaking points for today. So some states operate in a fee-for-service Medicaid environment in which the state Medicaid agency pays providers directly for specific services. They're usually billed in 15-minute increments. That's the fee-for-service Medicaid environment. In other states, and more states, their managed care is used and capitated arrangements that make monthly per member per month payments to one or more managed care organizations that manage provider networks and perform functions like claims payments, utilization management, and authorization of services are used. So Medicaid payment and delivery is different from state to state. There is no cookie cutter. There's no one way to learn it and then know it across the country. It looks very different in each and every state. Next slide, please. Some states use state plans, as John mentioned before, Medicaid state plans and waivers as funding mechanisms for family peer support. Medicaid state plans are contracts between states and the federal government. They outline the scope of the Medicaid program, include the covered groups, the covered services, and payment policies. States that include family peer support as a billable service under the Medicaid state plan, you can see up there, include Arizona, Kentucky, Massachusetts, and Oklahoma. And the Medicaid state plan allows any Medicaid eligible child to receive the service. States can also use waivers, as John mentioned before, to test new or existing models of service delivery and payment, allowing Medicaid to pay for additional services that are not covered in the state plan or that would otherwise be ineligible for the federal match. And some states fund family peer support through the 1915 C Home and Community-Based Services, or HCBS waivers, which allow for long-term care services to be provided in the home and community-based settings. And he referenced the PRTF, or the Psychiatric Residential Treatment Facility waiver. That was a 1915 C Home and Community-Based Services waiver. So waiver dollars include both state and federal money, and the Medicaid waiver must also be approved by CMS. A couple of examples of states using waivers: Georgia, Indiana, Kansas, and Maryland. Next slide, please. So financing for family and peer support, in addition to the Medicaid looking different, the financing looks different from state to state as well. In some states, family-run organizations can bill the state directly as Medicaid providers. In other states, these organizations provide direct peer support services through subcontracts, either with traditional providers who do the Medicaid billing, or in some states like New Jersey, for example, the family-run organization is funded through Medicaid administrative dollars, which is technically not considered billing for Medicaid. In Massachusetts, for example, family peer support is a standalone service. It's part of the state plan. In that way, it's available to all children and families that meet medical necessities for the service, whether they're in outpatient counseling or just getting out of a residential treatment facility or in a care management entity. As long as they meet the medical necessity for the service, they can get that. So I saw a question come through about how clinical family and youth peer support is. And what I want to say about Medicaid is that any Medicaid billable service, any Medicaid reimbursable service requires medical necessity. But it is up to the state to craft the medical necessity criteria, and oftentimes that's a handoff to the managed care organization. So it really is important for the family-run organization that's talking with your state Medicaid folks about what they provide to help them understand what it is that you provide. Because it is not, there are clinical components of it, and there's a value added, and there's a clinical piece to it, but I also appreciate that it's not a clinical service as traditional services or clinical services, and I'm thinking maybe Jane Palal will address that a little bit in her portion as well. So Yeah, and there are still other ways that Medicaid pays for family peer support. In California, for instance, Medicaid funding for family and peer support is under other service titles like community support and case management and resource development. Other states still are piloting programs to test different payment arrangements for the family-run organization before it begins delivering and billing for Medicaid-eligible services, and Lisa may say some more about that during her presentation. Next slide, please. Because states are matched or reimbursed with federal funds, when a family-run organization becomes a Medicaid provider, they are subject to Medicaid auditing procedures. And in some ways, this process is similar to the internal financial audits that family-run organizations are required to have each year no matter what. But Medicaid isn't short on rules and regulations, and audits become more complex as the organization's budget grows and its contracts are diversified. Medicaid contracts with entities that are called audit Medicaid integrity contractors, and they conduct post-payment audits of Medicaid providers throughout the country. So I think the takeaway from this is that there's a need for family-run organizations to develop an infrastructure and internal processes to ensure compliance with the Medicaid regulations, just as you would be audited by a managed care organization or a provider organization that you subcontract with already, that those audits are then in addition to a potential Medicaid audit for a family-run organization that becomes a Medicaid provider. Next slide, please. So historically, family peer support has been funded by sources other than Medicaid, federal grants, state and local human service authorities, but not Medicaid, and perhaps for that reason, family-run organizations, in my experience, do not, as a rule, have strong relationships with their state Medicaid agencies. If there's one main takeaway from this portion of this webinar, in my mind, it is to become familiar with the Medicaid policies in your state and to engage with those state partners early and often. All state partners, but particularly Medicaid. Learn what they do and how they do it, because as I said, it's different in every state, and not only as an advocate, but also as a business partner. Medicaid is insurance, it's not human services, so it's not likely to understand as easily or in the same ways as other state mental health authorities or child welfare agencies are. Establish the relationship. In some states, it would be with a Medicaid agency directly. In others, it would be with one or more managed care organizations. And in other states, it would be both. And help the state Medicaid agency to understand what the family-run organization does, using language they can understand, like data and outcomes, and also the value added that your organization can bring to the table related to policy, service design and delivery. I'm thinking Jane Cullow will probably speak to that shortly as well. And I am actually going to hand off to Lisa, I think, after this slide. So I thank you for your time, and Lisa, it's all yours.
Good afternoon, everybody. This is Lisa Conlin. I'm with Parent Support Network of Rhode Island, and I'm going to talk about really thinking about the key considerations and the steps you take as you're wanting to become a Medicaid provider within a family-run organization. We are into this, I would say, about 3 years, more as Diana referred to, piloting and testing. We are not directly billing Medicaid as of yet, but I am going to talk about the building steps that we've been doing over the last 3 years as we're working towards that work. I would say, as it relates to being part of state partnership and whether something's within a waiver or a state plan, Rhode Island is a state where we have been going through numerous statewide waivers and reform, and some of those global waiver even opened up our whole state plan. So it's been most important, I would say, over our years as the family organization to really understand Medicaid and what that means to the families we're helping to support and serve and represent us every day, to then how we're going to see our role within the work as a Medicaid provider. So first and foremost, as a family-run organization, you're looking at your own mission. So we have had discussions from a board level, staff level, focus groups with families and youth and our state partners and other Medicaid providers. Just understanding our mission, I can say, you know, as we were hearing these steps being taken over 5 to 6 years ago, we were like, where are we as a family run? Are we ready to take this on? We do a lot of different types of activities and supports and direct service as a family run organization. So not everything we were doing would equate to a Medicaid billing environment or providing direct service, but is definitely of benefit to our mission. So we're doing a lot of group support and education and learning, social activities, a lot of focused on organizing and building family, youth, and leadership. But then also we've had a core direct service component of our organization, which has really been that individualized, one-to-one parent education, support, guidance, service navigation. So we really were building a service delivery model over the years, going for us all the way back to 1992-93, where we were really building a strong program. So we had to take our practice model and begin to look at best practice models out there for parent and youth peer support and begin to say, what are we providing and how does that match up to Medicaid service definitions that may exist or not exist. We were able to, starting about a year and a half ago, we partnered with our state partners with the Department of Children, Youth, and Families, and then also our lead Medicaid office through our Executive Office of Health and Human Services to build a definition of peer and youth, parent and youth peer support. That definition had to go up to the Medicaid level. It's still in process of coming back to us so that we can really organize towards that direct billing level. But we have to first start on a common practice model. We've been working, especially in partnership with our wraparound delivery model in Rhode Island, both at a behavioral health and child welfare, juvenile justice context, to really begin to see how this model operates. And we worked in partnership with our child welfare Institute out of Rhode Island College and the Medicaid office out of our Department of Children, Youth, and Families to make sure that we were building a family support partner, which is our most important service that we want to see Medicaid reimbursed from a peer support perspective. And we have been able to go really far now developing a full certification process that as we step towards the next steps of becoming Medicaid reimbursable, that we would meet those certification requirements. So as we're building and thinking about service delivery, how does our own practice models, where are we in our own steps of a direct service program model, how does that connect with the overall practice models and connecting with to then how do we define that at a level of Medicaid service definitions and the training and certification that would keep us at a competence level. We also had to look at our own internal infrastructure as the family-run organization. So it was really important as we were looking at the skill sets of our own bookkeeping and record keeping, our management information system, really making sure we had moved up to a level of HIPAA and high-tech compliance. We worked because we were piloting and testing internally, you know, working with a workforce of family leaders, many who had not had a documentation or working with data or on systems. That was a big step and leap for us as a family-run organization. So I said, you know, we're going to need 2 years of really practicing how to do this work to the level of requirements that would even get us to a good level of direct service productivity that would keep us in a good, healthy place financially. So we started working with our staff on how to make sure that we were shaping our own management information system, developing progress records, keeping time duration, attaching our work to goals and treatment. And this is work that we've been working really hard with. We subcontract now with a lead Medicaid provider agency that is more in the seat, as Diana was saying, to do subcontracting with state to do the direct Medicaid billing, but we're learning a lot in that relationship and have set up an actual clinical co-supervision model where we have a family support leader doing supervision in partnership with the clinical supervisors from that agency. And all our staff now are meeting the requirements of getting that supervision. Our next step is we send a level of our records over to that agency, and now we're working towards the building blocks of how do we create and get the appropriate licensing within our own state so that we can be ready to do Medicaid billing directly. Quality insurance is, again, really important too, and being able to really look at our staff productivity and that the services and direct work that we're doing does meet the correct definitions of Medicaid service definitions, so we're not doing work that would be different or informal or more driven by what our families are looking for, that we've been able to do much more creatively and broadly for our families who would not be formally enrolled and more who through self-referral or learning about us get connected. So these areas of getting the right policies in place, having the right clinical oversight, getting the right service systems, getting staff working to that level of infrastructure, we are now, after 2 to 3 years of practicing this, really ready to step up, I feel, in a proactive way to take this next step into Medicaid. With the financing, again, I think every state is going to look very different. I think just lessons learned from my other peers that are doing Medicaid billing and financing is you have to really negotiate a good rate. In our state still, the parent peer support work that is getting billed for more through those direct Medicaid agencies is within a bundled rate right now. So we're still at a place of how do we get to our own rate and what will that look like as we take those next steps, and we're just starting to have those types of discussion. Cash flow is another piece. Many of us as family-run organizations don't have large capital, so you have to think about negotiating. Is there a startup cost within the contract? So much money coming forward, because most of this work is going to be done in a cost reimbursement environment. So that means you got to be able to keep your cash flow going and the staff delivering until you receive that payment. So the financing piece becomes really important as you think about this. Staff training, all of this in addition, not even only the practice model in regards to meeting the service definition and certification, but really as you're looking at staying in compliance with all the Medicaid rules and that clinical relationship is going to be really important. And I think it's continuous, and it's having good coaching and support mechanisms in place that really allow everybody to feel proactive and good about the work that they're doing and seeing the outcomes delivered. I think the last two things I want to speak to is it's really important from our point of view that and back to the mission of who we are as a family organization, that we're not changing our model to become just a service provider overnight, but that we're really staying connected to the populations that we're serving. So there is going to be families that come through a very formal enrollment or referral process, and that is tied to Medicaid billing and eligibility, but that we always want to make sure, based on our mission as a family-run organization, that we also are diversified in our funds and grants and contracts and such, so that we can do that level of informal support that's free of charge. We may be doing some level of intake or strength-based assessment with families, but it's not driven on them having an eligibility criteria for getting that support. And we know that a large number of our families get that. If I was to give you a snapshot today, 238 active families in our organization just in the last quarter, but of those 238 families, our pilot is working with 66 who I would consider to be that real formal service delivery under Medicaid relationship. So if that helps you to see the picture. And we're still doing lots of work in regards to family and youth leadership, social marketing, educational trainings and groups, though we are even looking at some of the family education, both individual and group, how, especially as we're using evidence-based family support curriculum, how we can get that Medicaid reimbursed also. And then as far as advocacy, I think that it has not been a challenge for us to keep our advocacy hat and move towards this direct Medicaid provider service provision. I think one lesson learned is we were at all the tables already doing a lot of strong leadership and advocacy work. As we started to be more of this contracted world or a provider network world, we were being placed at tables differently as an organization, but so were all those other contracted partners. So we weren't being singled out that it was following whatever a fair contractual process would be. But I think what was really important is the voice of our families and youth themselves really being well organized. And I think from doing this direct service delivery work and getting much closer with our state partners, we have been able to really recruit more families and youth. We're stronger advocates because we have increased knowledge of the service systems because we're working much more closely with the family and tackling with them the different challenges they're coming across. So it does give us another level of knowledge to be able to organize with the families and increasing the voice and learning in those particular areas. So those are really our building steps, and I think really important to taking those steps to becoming Medicaid reimbursable. And now that we're 3 years in and we're getting these service definitions and certification and our staff abilities in place, we're really ready now to go negotiate and get our licensing and the other steps we need to in place so that we can become direct Medicaid providers ourselves. So I'm going to step back and turn it over to my peers who have actually been billing in the Medicaid world. And I'll turn it over to you, Jane Clow.
Thank you, Lisa. Yes, I'm Jane Cowell, the founder and executive director of the Family Involvement Center in Phoenix, Arizona. Our agency was founded in, family-run organization was founded in 2002, and we have been a Medicaid services provider of parent and family support services since 2005. So we're quickly approaching our almost our 10th year, and today I will be focusing on how we became a pioneer in this area and how we did not do this alone and how the partnerships evolved. Before I get into that next slide, I'd like to say that it was really the systems partners in Arizona who recognized the potential that a family run could be an effective and valuable partner in providing peer and youth support services, and they saw that through our ability to bring parent leaders and expertise to the system planning, general system planning activities in our state. I'd like to now move to what the structure looked like in those early days. The focus of my discussion today will be how we got started as a Medicaid provider. Our first steps to becoming a provider were like any other family-run organization. Whether you're a new organization that's 2 or 20 years old, you'll find that becoming a Medicaid provider is a new way of funding parent and youth support, something that your agency has probably already been doing, but it necessitates other learning, new contracting, and infrastructure changes. Thus, it's important to take the time to build or strengthen those relationships and learn the roles and functions of all of the state partners you'll be working with, Medicaid, mental health, the Medicaid agency for your state, the licensing agencies, as well as the managed care organization or organizations and providers in the area that the state or community that you'll be contracting with. In Arizona, as I mentioned earlier, we had already been recognized for our ability to bring together parent leaders and family leaders with expertise to help in general system planning. So as we came to the planning table, that group included not only leadership from the family run, but it was family advocates, recognized family leaders who had expertise in different areas of children's services. Can I go to the next slide? Yes. This is a picture of what it looked like in at our state level, and also was replicated at the county or local levels in the planning for us to become a Medicaid provider. The successful implementation of large-scale family and youth support services in Arizona is generally associated with our having systems partners at the planning and decision-making tables, along with family runs and the community leaders and advocates. As you'll note on this slide, as I mentioned, it's a family-run organization, or at the time there was one at the table. Later there were 2 family members. We had health services representatives, education, child welfare, juvenile justice, and behavioral health. Through the work of planning committees like this, who had decision-making authority, 40 family support positions were launched after a 2-year planning process. This type of planning process and continual monitoring and refinement of the implementation model resulted in another 60 parent and youth support worker positions being added within the next 2 years, getting to around 100 in less than 4 years. The first step for any family run is learning about your state's mental health system, health plans and waivers, system of care goals, licensing regulations, and models for contracting for Medicaid service delivery. Becoming a Medicaid provider isn't a quick process, and with family runs, it is critical to take every opportunity to learn about how all parts of your children's system works together and how your organization can prepare for this process. A few examples. With learning to understand the workings of the Medicaid system, explore how rates are set, how service descriptions in your Medicaid covered services guide for your state are established. Try to be active in working with the planning for this. Also learn about billing codes. What is covered? What is the description of what can be billed? Get to understand documentation, electronic health records, the requirements for audits, and the staff qualifications. It's also equally important to learn what licensing rules will apply to the type of provider agency that you are aspiring to become. There are 2 categories in Arizona. Functions of managed care organizations, providers, methods of contracting, and categories of funding are all components that you're going to want to have some understanding of. As Diana and others have stated, there are a multitude of ways that this contracting and your agency can be established. While this can be a steep learning curve for a family run to take this on and try to move towards, in a test model or phases, it can also greatly increase the skills and knowledge of your leadership, staff, and the families you serve, and increases your ability to become systems advocates and to also work closely with the provider community and helping them, the general community of providers, to reduce systems barriers and improve outcomes for families. Together, we have worked with the provider agencies and other systems partners to successfully advocate for many changes, such as bundling of rates, bundling of services, and the rates for those services or the individual service rates. We've brought change to respite provider categories and rates. We've also continually looked at how in-home and community-based support services, which is where our family support and youth support workers generally provide their services, how those rates can be comparable to what our costs are. And I do want to mention here that as this was being developed, the approach for providing peer parent support and youth support services, the staff were going to be hired and employed not only at the family run but at other providers. So the package that we were developing for our system would go across the whole provider system. Without the long-term involvement that we've had in systems planning, we would not be in a position to be prepared to work on the complex issues that system advocates need to be aware of today and understand. I'm going to also reference Diana's earlier comment too about some of the challenges of looking at peer parent support and not being seen as a clinical service. We are continually working on those issues, and the table, planning table that I showed in an earlier slide really exists in different ways throughout our communities at the local, regional, and state level. And family voice from the family-run organization, as well as the community and the broad array of different types of providers and the managed care organizations are all at those tables. Okay. Systems partners coming to the planning tables are also often surprised and impressed by the depth of the ways in which family runs work with the families of children in the mental health system, and how they also are very strong partners with the provider community in working towards shared goals. A role that is often associated with the family run in our state and others is that we are a liaison or a bridge builder, and that certainly reflects the partnerships that exist not only at the system level but in the community of practice. The three most often noted benefits or roles that the family runs bring to a community beyond their delivery of parent and youth support is that they develop family and youth leaders for systems advocacy. They provide universal family support before and after a family receives Medicaid-funded services. I'm really reflecting on what Lisa mentioned earlier, that we are serving families and providing parent-to-parent support with other funding sources where the individuals do not have to meet eligibility requirements. It's universal support, assisting families often in discovering and seeking services, and we serve as a link or liaison to getting families enrolled through the managed care organization and the contracted providers for general clinical services. Another is the role that the family runs play in training and developing frontline non-family workforce in how to engage families and what family-driven care is for the workforce. These functions, along with family and youth support services, are all intertwined with the goals and mission of our organization and make for a very strong family support and family leadership infrastructure, which is the core of any family run and their goals for family-driven care. From what I've covered so far, I think you probably have picked up that it's a balancing act to be a family-run organization, stick to your mission, be able to be a systems partner, and to be an effective provider of peer family support and youth services. It's a balancing act, but they go well together. Because family runs have a deep commitment to both, because the family runs have such a deep commitment to these primary roles and program activities, they are continually connecting and developing more family voice in their community to continue to represent the needs of families at policy and program design tables. There are many strategies that are noted when looking at family runs and how family runs do self-assessments of their own organizations and their success in this area. The strategies for being both a Medicaid provider, parent and youth support services, and a system partner that brings family voice to the policy and program design are really tied in with programs that we have that make sure that we keep a strong component within our agency of being a training and technical assistance resource for family professional partnerships. It's quite a bit of what our agency does in our community, providing that type of training. We also look to an annually plan and with strategic plans, business plans, to diversify our funding so that less than half of our revenues go to Medicaid-funded services. That means that we continually look at foundation grants. We also have other administrative dollars that are provided to our agency through the managed care organizations, or in some instances state contracts, to provide the other elements that are not in the service delivery area. We also have focused on, and other and colleagues at other family runs are all that are becoming Medicaid providers are also making sure that they have an empowered board and family leadership that is continually linking the other roles that a family run provides the second role that's not the family services. Now I wanted to drill down a little bit to becoming a family-run that provides Medicaid services and how to get started, the practical steps within your agency. And what I'm going to cover here is really how this needs to be occurring while you are partnering with systems partners to learn about how all of the various components of what makes a children's mental health system and the Medicaid funding that allows us to continually improve our community and state services for families and youth. The first is to begin to develop a business plan with the input of your board and community, parents and youth leaders. The second is to define the parameters that you want in place to stay true to the mission and maintain systems advocacy. I've kind of touched on that. It's really around diversifying funding and making sure that you are doing the other necessary elements that make that allow your agency to continue to be an effective family-run organization. Also, define your practice model, the mix of Medicaid funded family support and other family support. Here I'm referencing how does your practice model for delivering family and youth support complement or run parallel or intersect with the other types of family support and youth support that you are providing with non-Medicaid dollars. Also, in doing this planning, look at the safeguards that you'll need to ensure sustainability of vital non-service delivery programs. And that, again, too, relates to clearly articulating in the work that you do with your systems partners or the community, the broad role that the family-run plays in a community by both supporting families through formal services and the myriad of other ways that they support and empower families and increase system involvement. Okay. Now I'd like to move on to how you work with the systems partners, and this is something that you would begin early on. The discussions that you have at planning meetings may relate to work that the state agencies have to do, but also you need to be learning from them some of the business aspects and some of the other things that you're going to need to know before redesigning your infrastructure. So begin to explore contracting options early with the managed care organization, the provider network, or both. I mention this because we have been funded for the family support and youth services that we are as a hub of our agency by both the managed care organization and by provider networks. And in the areas of Arizona that we serve, we have different arrangements and different combinations of this, and it can change from year to year or, you know, as policies and things in our state change. Also present your costs for service delivery. Don't wait and see what the rates might be. Start learning to, as you adjust your programs or you plan your startup, be prepared to calculate those rates based on a different model of service delivery. And understand that there are options when you're looking at negotiating rates. And it may, and evaluate the changes that would be necessary in your service model. Also, define and agree on how parents, caregivers, and youth will have access to your services. The relationships that you will have with other service partners, how are you going to all be brought to the table with the goal of improving access, voice, and choice, and outcomes for families. The next is I wanted to basically review one more time how a family-run will maintain its effectiveness in the community. A community that has strong family runs will be seen by the community and state and county systems as a place where there is universal family support and options. They'll be able to, the makeup of staff, the support services, the staff they employ in support roles will be representative of the community. And that same group of families will have the opportunity to be involved in family and youth leadership roles at different levels of the system. The family run will also be recognized for its workforce development of parent and youth support roles and team facilitators and often systems administrators, educating them on the role of how family and youth support is complement to clinical services, how the various roles work together. And also finally, that quality monitoring is a role that the family runs are active in.
Okay, thank you, Jane.
Jane, I'm sorry, my screen just went black, so I think something has disconnected. I'm glad you can hear me. Thank you.
Okay, so this is Jane Walker again from FREDLA, and after an hour and 6 minutes, you may be asking yourself, why would any family-run organization want to become a Medicaid provider? It's not quick. You heard that it can take years to gear up. It's not easy. It's complex. You heard that it's different in every state. There is no cookie cutter. It can be funded in various ways. And Medicaid funding is not the be-all, end-all for any organization in terms of sustainability. It's one piece of a puzzle. So it's up to the family organization and their board to really weigh the pros and cons and see what's best for their organization. A lot of this has already been said. I'm just going to quickly do an overview. You heard that it really is a culture shift for a family organization. We were all started out of lived experience. None of us got into this work because we wanted to be accountants. It's our passion. We do it to help other families. There used to be a saying, family support whatever it takes, and becoming a Medicaid provider changes that, some would say, to family support whatever you can bill for. I'll give you an example of this from the state that I came from prior to joining FREDLA. We had a family whose child was taken to the emergency department for evaluation and possible admission to a psychiatric facility. The family requested that the parent support partner accompany them to the emergency department. In previous times, no question would have been asked. The parent support partner would be there for whatever it takes. However, we all know that emergency departments take hours, if not days, and the parent support partner ended up staying with the family for 10 hours. Of course, in a fee-for-service system or Medicaid billing service, Medicaid is not going to pay the family organization for 10 hours while the family support partner remains with the family. Yet, the family organization needed to pay the family support partner for the 10 hours that they were in there with the family, and in the end, the family organization loses money. And we know that no business can operate with that type of loss. So what had to happen was a change in practice so that the parent support partner may accompany the family to the emergency department, stay with them while they complete the paperwork, make sure the family had food, contact information to complete all the paperwork, and the child's doctor and anything else. And then they leave and periodically may call, or the family may call them. So you can see from this example how dramatically the culture of the organization has to change in some cases. It's also important not to let Medicaid take over every aspect of the organization. You heard that I think Lisa said the number of families they're serving who are on Medicaid, but a much larger number who are not on Medicaid. There's other aspects of the organization that Jane referred to in terms of community events, children's mental health awareness, trainings, celebrations, all those kinds of things. It's important to preserve the heart of family-run organizations and activities beyond just Medicaid billing. There's always a lot of emphasis on the administration in Medicaid. Becoming a Medicaid provider necessitates not only more documentation, but accurate documentation. And the administrative work can increase exponentially, and the emphasis on administration could take over the organization. Several times it was mentioned that family-run organizations must understand payment methodologies and rate negotiation. Family-run organizations have to go into this with a clear understanding of what is covered, such as phone calls, training, supervision time, travel, and in also what increments can be billed for, whether you can bill in 15-minute or 1 hour, or is it limited to 1 hour per day. These are all the nuts and bolts, but digging into them is critical to the survival long-term of a family-run organization. Lisa mentioned having the necessary financial resources to absorb the costs, the startup costs, and to be able to ride through periods when cash flow could be a problem. If the census, the number of families being served goes down, you're not able to bill what you were. It's certainly a different financial setup than knowing you're going to get a grant that is X amount of dollars and you can expect a check divided by 12 every month for that particular grant. It doesn't work that way. Payers may view family-run organizations differently. When setting rates, Medicaid may use things like credentialing as a benchmark for rates. In other words, they pay clinicians with a master's degree a certain rate, and if the family organizations aren't employing people with master's degrees, which most likely is not happening, then they're automatically, the rate is set lower. And to us, the most important credential is lived experience. So understanding the rationale behind the rates, what's included in the rates, and any boundaries on the rates, like the number of hours you can bill for. Again, can't say it often enough. And then strict adherence to Medicaid regulations. I'll give you another example. The state I had been with previously, we were a Medicaid provider, we had a Medicaid audit, random file review, and one of the contact notes completed by one of our parent support partners neglected to include the end time of the contact. It had a start time, but not the end time. So there was a question about whether this was a 15-minute contact, a 1 hour, or what exactly it was, and we had no documentation to support that it had been 1 hour. So, however, those regulations are Medicaid and cannot be bent. So, is there then anything good about becoming a Medicaid provider? Well, the answer is a resounding yes. There are many benefits to becoming a Medicaid provider, and these include, but are not limited to, and I'm going to go back to the first bullet that was on the con, which is a culture shift. That culture shift can also be a big plus for the organization, and that's by raising the level of professionalism for a family-run organization. The staff members begin to view themselves differently. The organization itself becomes much more professional in its services, its operations, and its image. Peer support itself becomes more focused and more outcome-driven. In order to bill Medicaid, parent support providers have to be working toward goals, often have to have their own plan of care. Of course, all of these are developed with the family, but the parent support partner has to begin asking themselves, what am I going to accomplish with this family during the time that I'm with them? If one of our goals is to get this child back in school, what do I need to be working on today to get to that goal? Before Medicaid billing, again, where I formerly worked, I think parent support partners sometimes viewed themselves as best friends and that was their role. That perception has long gone and has changed as a result of being more outcome-driven. Being a Medicaid provider also means that a family-run organization are part of the service delivery system. And that is a real plus because there is the ability, the state then begins collecting data on utilization of parent support services, and there's a greater capacity to get data and realize the impact of parent support in the lives of the children and families. Depending upon how a state has structured its payment, remember early on, Diana said it could be either through a waiver that would have a very specific number and a cap on the number of children, or it could be a state plan amendment, which makes it an entitlement for any child on medical assistance. The population served could greatly expand under Medicaid billing, and the family-run organization could potentially serve many, many more children through the Medicaid. Medicaid fee-for-service is not capped as a grant is. That means if you're serving 10 children, you can bill for 10 children. If you're serving 20 children, you can bill for 20. If you're serving 100, you can bill for 100. Whereas with a grant and you're getting a specific amount of money, you may only be able to serve the 10 children. So that's another benefit to being a Medicaid service provider. And Medicaid billing is more consistent than a grant, meaning it's ongoing until there's a change to the state's Medicaid regulations, unlike a grant where there's a start and an end date, like July 2013 through July 2014, and then you have to wonder, is the grant going to be renewed, and maybe have to go through a whole process to apply for a grant again. But if you're a Medicaid provider and the regulations haven't changed and you've met all the auditing requirements, you continue to bill for services. So again, there is a lot to consider from many, many aspects. The publication that we referred to very early on, at the end of it has a readiness tool for family-run organizations, very comprehensive, looking at all of these different aspects, the mission, the practice, the administration, the financing, rates and the diversification and sustainability. This publication is available on the Center for Healthcare Strategies website that you see there. And also the what Diana referred to early on about the scan of states, which looks at what states and how states are using Medicaid to fund family support services. So there's the website, and this webinar is also going to be available on the University of Maryland Institute for Innovation and Implementation website. It will be available on the FREDLA website and the Center for Healthcare Strategies website, where you can also get the state scan and the publication that we've been talking about. So check out the readiness tool. We have decided in preparing for this that there was so much content that we really couldn't cover it all. Like, we haven't even scratched on rate setting or staffing and preparing staff, documentation, those kinds of things. So we will follow this webinar up with a second webinar that is going to go into much more depth on the financing issue, the rate setting, and the staffing considerations. And finally, if this is your first introduction to Medicaid billing, you are possibly more confused now than when we started. And if that's the case, let me tell you, you are in good company. This is not simple, and of course, it differs vastly across each state. Because we know so many family-run organizations are contemplating or starting to become Medicaid providers, FREDLA is going to be developing a learning community for a small group of family-run organizations that are in the early stages of becoming Medicaid providers. This is going to be an opportunity to get ongoing technical assistance, as well as learn from your peers from other states who are probably about the same stage. We're going to be sending out more about this opportunity in the next few weeks. So with that, I want to thank our presenters, John O'Brien, Diana Simons from the Center for Healthcare Strategies, Jane Kalal from the Family Involvement Center in Arizona, Lisa Conlon from the Rhode Island Parent Support Network, and to all of you who joined in this webinar. We have only about 10 minutes for questions, which I believe, Adam, I am supposed to be reading these questions, and then I will ask any of our presenters who would be interested to answer them. So our first question concerns the issue of too clinical. Diana touched on that, and I think Jane also. The question is, should topic not already be planned to be addressed? Any insight into how to address the concerns of making family support too clinical? Several of our family-run agencies get stuck around these points. And a follow-up to give examples too clinical, the primary arguments for moving forward that we hear is that family support is prescribed and the documentation burden and peer-to-peer treatment planning. Jane, Diana, do you want to answer that?
Sure. This is Diana. I can take a shot at it. So, you know, Medicaid requires medical necessity, and there's a rub there because a lot of the activities that family-run organizations provide are around mentoring and coaching and education and driving and doing things that are really not clinical in nature. However, there is, it really comes down to how you structure your definitions and how you work with the partners in defining peer support and learning the Medicaid speak and learning the language that you need to know to put forth the service. So one of the shifts that we're seeing is a move from clinical to holistic, and I think John spoke about that, and I think that, you know, the integration between physical and behavioral and also the social support, the whole system of care philosophy that's now taken hold, finally, 30 years later, is moving toward the understanding that people are more than just the clinical pieces of themselves. So there is, I think, the opportunity to broaden the understanding of what the value-added components of family-run organizations are. But I do think there is a requirement there. It's a hard requirement that there be medical necessity, and how that's structured makes a difference. So we're happy to share, you know, I can send some folks the medical necessity criteria for family and peer support in Massachusetts if that's useful to take a look at. It's a broader definition that includes education, that includes coaching, that includes mentoring, those kinds of things. It really is up to your state in defining that, your state Medicaid agencies, and that's why, for my money, get to the table early and stay there. And Jane Callowell, if you want to add anything to that, or any one of the other folks.
Okay, let's move on to the next question. Is a model of state-focused and mutual development more appropriate for these models, or a national model for certification licensing of peer support personnel the most appropriate, given the variations across the states? So I'm assuming that's certification of peer support, and we're actually going to be touching on that in a webinar in June, where we're going to be talking about the state option and national option, and there are also options in between those two for certification. So I would ask that you hold tight, and we'll be talking about that in June. Our next question is, in states where there is a model for an ACO for centralized billing useful to work with, or is it too early in the process? Following up by, I heard understanding of both HIPAA and high-tech mentioned, but no mention of 42 CFR Part 2, which often is confused as being subsumed under HIPAA, when in fact it is different, more prescriptive in many ways, and interacts with high-tech than HIPAA.
You want me to take a shot at that? It's Diana.
Yeah, please.
Yeah, okay. So the two separate questions. So the ACO, if your state is looking at a model for an ACO for centralized billing, I would say get to the table immediately, don't wait. And that's a rule for any kind of redesign, because that ACO is going to be the accountable care organization, and they need to understand the value added that your organization can bring to them, because that expertise, whatever the ACO is not going to have the expertise of a family-run organization unless they already have a family-run organization as part of their core. So yes, by all means, get involved now, get to know them, get to the table, have conversations with them. And the second question around 42 CFR Part 2, that actually has to do with confidentiality related to substance use, drug and alcohol use in particular. So my experience with it comes from my participation around the conversations that states have with SAMHSA and with, particularly with SAMHSA, around their health homes initiatives, which many states are looking at. It seems like there's a push to have a standardized release of information or confidentiality agreement. 42 CFR applies specifically for releases of information and confidentiality. And to the extent that it does, states usually have regulations in place around that. And they need to be able to articulate what those regulations are and what their standards are to the federal government in a way that they can understand. Because the federal government will push that and will say, do you have standard 42 CFR Part 2 regulations? Have you incorporated it? The ASAM website is a good resource for information around that. And there's a really good, it's www.asam.org, and they have a very good question and answer and FAQ on 42 CFR. But ultimately, it's the responsibility of, with limited exceptions, it requires patient consent for disclosures of protected health information, and that's true of all of us. But all states have that in place for their providers, and you just need to find out where your state stands and be able to articulate that. So that's
okay. We have quite a few questions, one of which was, please put up the site for the readiness tool. So I've already done that. We have another question about, can you share what rates might look like? I would, again, suggest wait for our next webinar when we're going to really dig into the rates issue. One question, do you have suggestions about how to work better and collaborate with family-run organizations? We could do a whole...
This is Jane Callow. I'd be glad to try and answer that. I think that in how to collaborate with family runs is a two-way street. When you start these planning groups and you're working on an issue for your community, provide the ability for partners to work together and understand each other's backgrounds before you start getting too deep into resolving the issues. And also, I think another area is that there be the opportunity for groups to, and events to be planned and orchestrated together. We find that when we do that with the provider system or the REBA, they get to know the staff, we get to know their staff, and it leads to natural collaboration that couldn't have happened, in a planning committee. I hope that helps.
Okay, we have run over our time, and so I'm very sorry that we can't get to all the questions. Again, the recording of the webinar is available at these three sites: the Institute at the University of Maryland, the FREDLA website, and the Center for Healthcare Strategies, which also has the publication as well as the matrix of states and how they fund family support services. So with that,
Jane, I just want to say, Jane, I was just going to say that there are rates in there. We have amounts, rate amounts in that scan for that question.
So check out the matrix available. Perhaps, can they find that easily on the CHCS website, or can we send out a specific link to the matrix?
We can send a specific link to the matrix. I'm not sure how to do that, but we can do that through maybe the TA network.
Okay. All right, will do. All right, everyone. Thank you very, very much, and happy April Fool's Day, everyone.